Hi everybody, this is Carlos from Army of Nurses and welcome to another video. In today's video, we're going to learn about the A to Z of critical care. This video is intended for nursing students or registered nurses who are undergoing their training in an ICU environment. And the purpose of this video is to assist some of the new learners in how to identify some of the needs that the patients have after they have completed certain assessments. Uh, from personal experience, I do find out that some of the new nurses or some of the new critical care students, although they do learn a lot of the theoretical concepts in class and they're able to practice it in the ICU, they often struggle to come up with rationales and also for to identify some of the priority needs for some of the patients that we have in the ICU. So hopefully this video, it's going to expose you in a systematic way for things that you will look for in your patient so that you're able to provide optimal care and patient and family-centered care for your patients. Now, our learning objectives are going to be you'll be able to differentiate between the ABCs to maintain and the ABCs to avoid during trauma. You will be able to identify the care required for patients in a critical care environment, and you'll be able to implement the knowledge that you learn in your critical care program in able to be able to anticipate some of your patient needs. Now, let's start with our ABCs of trauma. Just a little background. My background is in neurotrauma ICU. I have also worked in a medical, surgical, and cardiac ICU. So some of the ABCs that most of us are familiar with are airway, breathing, and circulation. Now, those are the ABCs that you want to maintain because you want to make sure the patient has a patent airway for oxygenation. You want to make sure the patient is breathing either independently or with some assistance. And circulation is going to be a big part of your management in the ICU because you'll be using a lot of inotropes, chronotropes, and vasoactive in order to maintain hemodynamic stability. Now, some of the ABCs to avoid that not a lot of new students are aware of is acidosis, bleeding, and cold. Now, these three are the deadly triads of trauma. Acidosis, usually the body doesn't like to be in an acidotic state, and the heart doesn't work properly when the body becomes acidotic, either through metabolic or respiratory acidosis. Bleeding or hemorrhage, the body doesn't like to be in the state because it becomes it needs to compensate in a very quick fashion, and sometimes the body, depending on the injuries, unable to compensate for the massive loss of blood. And hypothermia or cold, this is something that causes a lot of problem because it can slow the heart rate and also causes a whole bunch of coagulopathies. And in a patient who is acidotic, is bleeding, and is coagulopathic, as you can all see, these three, once you mix them together, they don't make a good combo for the patient, and it hinders their survival ability. With that being said, let's move to A. So A, like we mentioned earlier, is going to be for airway. You want to make sure that your patient is able to maintain an airway by themselves through a level of consciousness, or if they are in a decreased level of consciousness or they require an advanced airway, then we want to make sure that either one, they are intubated with an endotracheal tube, they either have a tracheostomy, or they have an oropharyngeal bite block or airway, so that we are able to protect the airway by avoiding the tongue from rolling back when they cannot control the tongue during when the patient is unconscious or if their level of consciousness is too low. Which brings us to the next one, which is breathing. Now, we want to make sure that the patient, one, is breathing spontaneously. Spontaneously breathing, the patient initiates their own breath and they're able to use their lungs and the diaphragm to bring the air in. Now, that might not always be the case especially if a patient ends up in the ICU. One of the biggest challenges that brings them into the ICU is respiratory support. Now, when that ends up being the case, you want to make sure that the patients don't have, again, it goes back to airway, they have a patent airway, so that their breathing it's also not hindered. And with the breathing, they want to make sure the oxygenation is maintained. and they have good lung sounds, to facilitate air entry on both of the lobes. Which brings us to C. C is going to be for circulation. Now, circulation is going to be related a lot to the cardiovascular system, and this is going to be one of your big roles as a critical care nurse, which is to maintain hemodynamic stability. And you're going to maintain hemodynamic stability through vasoactive, inotropes, chronotropes. What those medications do is they either increase the force of contraction of the heart, they increase vascular resistance, so the pressure goes up, or they maintain a regular heart rhythm so that your cardiac output it's efficient, and therefore more oxygen gets to the rest of your cells. Now, these are the basic three ABCs of critical care that a lot of students will learn in it. So, but the remaining letters are some of the things that you should look for, because they do we do encounter them in the ICU very, very regularly. And students, if you are able to identify some of these issues, it will really enhance your ability to perform as a critical care nurse. So our next letter is going to be D. Now, D is going to refer to distress, delirium, and DVT prophylaxis. Now, distress, as you can all imagine, when patients are in an intensive care unit, they have all sorts of tubes and lines coming out of them from the mouth. We're going to have IV lines, central lines. And a lot of time when we have to put a breathing tube into them, we have to either sedate them or sometimes even paralyze them. Now, you can imagine that when they wake up and they see all these random people around them, right, and in a new environment, it does get quite distressing. And that's one of the things that anxiety and agitation will come along with it. Which brings us to delirium. Now, delirium is very common in the ICU. It is characterized by sudden changes in neurostatus and also in changes in vital signs. Delirium, it is a medical emergency, and it should be treated as such because there's always a cause for it. Now, in the ICU, you're going to see that drugs are going to be one of the main causes of delirium in our patients. Number two, the lack of sleep. With the repositioning that we do to our patients every 2 hours to prevent pressure sores and to start mobilizing some of the fluid, you can see that sleeping is very, very hard in the ICU. Once you add on top of that the noises, the lights, the pagers, the codes that they call overhead, it's very hard for patients to get a good sleep. When that ends up happening over a couple of days, a few days, you can see that the brain starts to get tired and it's going to become delirious, and it will manifest clinically in the patient, which we must treat as a medical emergency. The other D is going to be for DVT prophylaxis. Now, we need to think about when patients are very sick and they're on a ventilator and with medications, they're not going to be ambulating, or they're not going to be in their maximum level of activity. With that being said, it puts them at a very high risk for DVT prophylaxis, because then they do have 2 out of 3 of virtual striates. They will either have the increased coagulopathy, they will have damage to endothelials, and they will have for sure the venous stasis because they do not move around. So we want to make sure that we think about DVT prophylaxis with the team as soon as possible, when the patient is admitted and if the patient is able to receive so, because it will enhance the patient's survival rate with thrombolytics if the patient is able to have them. Now, we're going to discuss about environmental safety, emotions, and elimination. Environmental safety is extremely important, team, because when you first go into the patient's room, even before you see the patient, you should do a safety scan of the environment for the patient's safety and also for your safety. What you're going to check for, you're going to check for this acronym. Especially for the iPhone users out there, this is going to sound familiar to you. It's going to be the iOS, which is your operating system, iOS A. So iOS A for your environmental safety checks, it stands for patient ID. You want to make sure you have the correct patient. You want to make sure that you ask the patient verbally and check their ID band. O is going to check for oxygen, the oxygen regulator on the wall. Make sure that the oxygen in the wall is actually working if you need to bag the patient, if you need to give the patient oxygen right away, you don't want to be stuck in a situation where your patient's desaturated and your oxygen in the wall does not work. And it has happened before, just sharing from personal experience. S is going to be for suction. Again, you want to make sure that your suction regulator in the wall is actually working. If your patient is vomiting, is feeling nauseous, you want to make sure that we're able to provide suction so that they don't aspirate. And A is for allergies. Make sure that the patient has an allergy band. In a lot of hospitals, it's universal to be a red allergy band. Once you check and make sure the patient has an allergy band, make sure that you know what kind of allergies the patient has. Next is going to be emotions. As you can all see, in an environment like the ICU, emotions do run high. And this is not only for patients because they're scared, but also for families, having their families in a critical care environment. It does causes a lot of negative emotions because of fear that comes in there. And if we are going to provide patient-centered care and family-centered care, we have to listen to patients' emotions, because that's going to be one of the things that it will provide some respite and some put the patients and families at ease that they are in a safe place under our care. Elimination could be from either urine elimination and bowel elimination. When the patients are very sick, we tend to prioritize the ABCs because those are our survival. Now, we also have to make sure that we keep an ear and keep an eye also for elimination, and because we want to make sure that, one, the patient's kidneys are working, and two, we want to make sure that patient's still passing gas so they don't get small bowel obstructions. So think about the different type of eliminations as well. Next letter is going to be F. Now, F, you're going to look for fevers, very common in the ICU, fluids, and family. Now, fever, everyone that's admitted to the ICU, once they do, could be due to an inflammatory process, could be due to infection, they do develop a fever. I also want you to think about all the foreign objects that we insert into patients. Urinary catheters, for instance. Some patients even have rectal catheters in them. Intubation, right? They have endotracheal tubes, intubation. IVs, central lines, PICC lines. They have all of those things that bypass our largest organ, which is the skin, which provides us with the best physical barrier for pathogens. But we bypass that in order to be able to provide some of the treatments that we give to our patients. Which brings us to fluids. Now, patients who end up in the ICU, they're usually very hemodynamically unstable, meaning that their pressure is extremely low. Sometimes their heart rate is very high or very low, and their cardiac output gets compromised. Now, as a review, your cardiac output is equal to your heart rate times your stroke volume. Now, by giving fluids, we are giving the patient more volume for them to work with so that their pressure goes up. Now, the problem with that becomes that as the patient stabilizes, they're going to be in an extremely negative balance because of all the fluids that they have been given. And it's just not just the boluses that you're going to be given, like saline, ringers, D10 or D5. Think about all the medications, the IV medication that we give to patients, and everything is mixed through fluids, and that adds up significantly. Next is going to be family. Just because we're taking care of our patient, it does not mean that we have to rule out or at least block out the family. Family support is extremely important, and you're going to realize, especially when your patient becomes agitated. We always try to do a least restraint policy, and restraint could be either chemical restraint or physical restraint, right? Because that could be a traumatizing experience for our patients in the ICU to wake up to be tied up to the bed or be, very drowsy because of sedation. Family, when they hear a familiar voice, a familiar touch, or a familiar sight of someone that they know, it eases their anxiety exponentially. So please try to include the family into your care as well. Which brings us to our next letter, G. Now, G, you're going to look for glucose and get up. Now, get up is going to be for ambulation. When the patients start to become more stable, we want to make sure we ambulate the patients, because ambulation is going to is going to enhance the patient's recovery. It's going to promote better circulation. It's going to mobilize a lot of the fluid. It's going to enhance the breathing pattern, right? And it's also going to enhance oxygen and carbon dioxide exchange. Now, with that being said, it provides strength to the patient. And once the patient becomes stronger, then they need less support from drugs or from machines, which is great because that's one of the requirements that we have for patients to leave the ICU safely. Glucose becomes very important as well. It's something that is could be something that is easily forgotten or just oversaw. Now, we tend to only check glucose on patients who are diabetic. But in the ICU, if you suspect that the patient it's hyperglycemic, for instance, right, and it's not diabetic, um, check a glucose. And one of the reasons could be because patients who come to the ICU with inflammatory processes, we give them a lot of steroids, corticosteroids or glucocorticosteroids. And as a result of these steroids, their blood sugar will go up exponentially because of glyconeogenesis that these drugs have. Now, this is transient, right? However, patients' blood glucose, even if they're not diabetic and they're getting steroids, they could also increase quite a bit, which is worthy and is also important for us to monitor that as well. Which brings us to the next letter, H. H is just going to be for hygiene. Just because they're in the ICU, and they're sick, it doesn't mean that they don't get regular care. They do get care, ADLs, and make sure that we provide the patient with a bath, right? It could be dependent on your institution, could be in the daytime, could be on the nighttime. If you are a little bit busy, at least give them a bed bath. And ensure that we maintain the patient's skin properly conditioned, and make sure that we at least wipe off some of the solutions that we use to clean the skin for procedures, and just make sure the patients are at least comfortable, and also give them some dignity, and also so that the families can come in and visit them as well. Next letter is going to be I. Now, for I, and here my face is blocking this one, but it actually says IV drugs, imaging, and isolation. Now you can see that IV drugs is extremely, extremely important in the ICU. And the reason why is because when patients deteriorate, they deteriorate very quickly. IV drugs, because they're very quick and very instantaneous in the way that they act, and it allows us to correct a lot of the medical emergencies quickly. Plus, because we do have monitoring in the ICU, we're able to see changes almost instantaneously. Now, the next thing that you're going to be thinking about is imaging. Does your patient need any imaging, right? If your patient is admitted with a traumatic brain injury, or if the patient was obeying commands and all of a sudden the patient is not, then maybe we should start talking to the team to see if there's anything that might have changed. And sometimes that could be assessed through imaging such as CT scans, MRIs, and PET scans, for instance. And isolation. One of the things that you always have to ask yourself for isolation, especially during COVID time right now, one isolation part that you have to assess is if your patient, for example, start to have diarrhea that is not triggered by laxatives, right? We have to make sure that you as a nurse, you put them in a preventive isolation in case you're suspecting, for example, C. difficile, until you collect the sample and you're able to get that clear up. But remember that you can never be too safe. So use the judgment as a nurse, as a nursing student, to think about that when you start observing, for example, diarrhea during your assessments. Next is going to be your J tube. And a lot of the patients in the ICU, they will have enteral routes of to get nutrition and also to get medications. Ensure that the tubes are at the marking that you get report. Ensure that you do follow your policies from institution to check for placements, either through auscultation or through aspiration of gastric content, checking for pH. Every institution is a bit different, but ensure that that's part of your assessment as well. K is going to be for a Kardex. Now, the Kardex, you have to check it regularly. And the reason why is because orders in the ICU, they change almost every hour. With that being said, medications, they change every hour. If the Kardex is not updated regularly, you can see that it creates a very big gap for medical errors to happen, which is why when you do have a downtime, make sure that we update our the Kardex, make sure that everything is accurate, and we double check all the orders to ensure accuracy for that as well. Next letter is going to be L. And with L, there's a few things that you're going to ask yourself. Does a patient need labs? Does a patient need additional lines, right? Labs, for example, in the ICU, if your patient is desaturating and your oxygen requirement keeps going up, right? And then you do see clinical changes, ask your team if they want to do some lab work, maybe an arterial blood gas, maybe do a lactate, right? So think about that at the back of your head when you're doing your assessments and some of the findings. Which brings us to the next one, which are lines. Now, line sepsis is very common in critical care. Now, the reason why is either sometimes when a patient is extremely unstable, the intensivist is going to insert a line to stabilize the patient and then change the line to a more sterile one if the sterility of the field was not 100% maintained. We always want to make sure that this is done under 100% sterile fields, but when you start practicing in the ICU and you see that when patients deteriorate very quickly, we will take priorities of stabilizing the patient and then change the lines shortly after that. Which brings us to the fact that we want to make sure that the patient, we take out the central lines, if the patient doesn't need it, as soon as we're able to, because these big lines, they go into one of the big veins in the body. And as you can see, because it goes into the big highways in our circulatory system, that if there is an infection, it's much more prone to actually cause sepsis. We try to downgrade them to peripheral lines, peripheral IVs, if the patient's able to, right? But that is going to be based on the requirements of the patient, what medications they're on, because certain medications are irritant to small veins. And we have to change the way we mix our drugs sometimes based on if there's a central line dose or it's going to be a peripheral line dose. Which brings us to M. Now M, you're going to check the MAR. Now this could be done concurrently with the Kardex, but some places they have the Kardex separate from the MAR, because nowadays a lot of places they have the MAR in their computer system. When you check on the MAR, you want to make sure again that the order that is written matches with the MAR that was transcribed by pharmacy, or if you're still in a unit where the nurses transcribe and it's done through a double check. Make sure the medications that are continuing or discontinued, that they are done so accurately, and make sure it reflects the orders as well. And if there's any discrepancies, make sure you bring it up to the charge nurse, make sure you bring it up to the team, and also you bring it up to the pharmacist as well, so that we correct that and minimize medical errors, and especially medication errors. Monitoring is going to be another thing that you're going to ask yourself. Now, most of the patients in the intensive care unit, they will be monitored through, a monitor that looks like this. Now, the amount of lines that you will have, that will depend on what you are monitoring for, and you can set this to whatever line you want to monitor, and you will learn that in your training in intensive care unit. Now, it doesn't mean that everybody in the ICU has a monitor. Some patients who are waiting for a level 2 bed or step down or waiting for the ward and there's no bed in the ward, right, and they're stable, they might not need a monitor, because then when they're in the monitor, it restricts them to the bed, right? And then it brings up at the issue that they cannot ambulate, they cannot mobilize. So sometimes if the situation warrants it, we don't always put a monitor, but I would say most of the patients in the ICU, about 95% of patients in the ICU, they will be on a monitor. Make sure that you check all your parameters in the monitor. Make sure you check your limits, right? Because if the limits exceed certain threshold, you will hear an alarm. And that alarm is going to let you know if the blood pressure is dropping too low, or if the heart rate is going too high, or if the oxygen saturation is dropping, it will alarm you for that, which is very important for you to check the limits and make sure that the silence alarm is not on, because when that happens and any of your numbers change, you might not be able to hear, and that could be a problem. So make sure you keep that in mind, okay? Which brings us to our next letter, N, nutrition. Something that is so easily oversaw sometimes in the ICU because we're so focused in stabilizing the patient. But think about it in the sense that when the body is in the state of emergency, when the body needs energy to heal, we need to supply it with food, right? Obviously, they won't be able to have a burger, they won't be able to have healthy food. So most likely you're going to be able to feed the patient enterally through formula. For example, the IsoSource 1.0, and you're going to be doing that through a kangaroo pump, which is one of the most common feeding pumps up there. And make sure that you include dietary services or the dietitian to assess the patient's caloric needs. And the reason why is because some medications, they do add calories, believe it or not. In the ICU, you will see propofol, for instance, as one of our anesthetics and sedatives that we very commonly use. And propofol is very high in calories. So when patients are in propofol, sometimes the dietitian might change the dose of the feeds accordingly until they're off. So don't be afraid to engage your interprofessional team in collaborating when it comes to nutrition, because everyone in the team contributes something important that other team members do not. So we all work as a team, okay? Which brings us to the next letter, which is O. Extremely important in the ICU, especially for patients who are intubated and patients who have tracheostomy. Make sure we provide oral care frequently, every 2 hours. Now, the reason why is you can start thinking about when patients have a breathing tube in their mouth, an endotracheal tube, their mouth is always open. They don't have the chance of closing it because the tube is preventing that from happening. As the mouth is constantly open, right, it dries out. Bacteria can always just go in and out, and bacteria start to grow in there. Once bacteria grows, you don't want the patient to develop any thrush, and obviously you don't want also patient to develop aspiration pneumonia, which is why we provide oral care and suction quite regularly. Make sure that we brush the patient's teeth. Just because they're intubated is not a contraindication for us to brush their teeth, unless they have trauma in the mandible, in the maxilla, but then your team is going to inform you of that. But as a general rule, make sure that we provide oral care for our patients with approved cleaning solution that your institution has, okay? Next letter is going to be P. And very important, pain, which is the biggest and the most common reason that brings people to the hospitals, right? And pumps. Now, ask yourself, when it comes to pain, is the patient's pain managed properly? And you're going to learn in an ICU environment that the subjectivity of pain sometimes is not enough. And the reason is because when they're intubated, they cannot verbalize their pain. And when they are sedated, they might not be able to communicate with you properly either. So then you have to go with objective ways of assessing for pain, right? So you can use a CPOT scale. You can watch for signs of grimacing, tachycardia, hypertension. So those are all signs that the patient might be in pain. So use your judgment accordingly to ensure that the patient's pain level is well managed, because when pain is not well managed, the body is not going to start healing. And we want to make sure that either we use proper medications for the patient, and we reassess the need for those medications on a daily basis. Which brings us to the pumps. Now, all ICUs will have pumps, the IV pumps, and we put practically every medication in a pump. And the reason why is because the pumps are able to deliver medication dosages in such a precise and concise manner that we're able to titrate medications very easily based on the patient's needs and based on what we see in the monitor. So become familiar with the pumps in your organization. In my picture here, I just have the Baxter pump, but every hospital has a different pump system, so you just need to make sure you're familiar with them. If you're not, ensure you reach out to the nurse educators to get some training on that. Which brings us to the next letter, Q. Now, you're going to ask yourself if the QRS, and this is part of your ECG training that you're going to get in the ICU. But when it comes to Q, you want to make sure, is the QRS wide enough? Does the patient have any blocks? And you want to make sure that the QTCs, the QT interval that are actually important. Make sure the QT intervals are between 350 to 500. And the reason why is because a lot of medication that we give in the ICU team, it prolongs the QT interval. Now, medication, for example, the Haldol, you have some of the antipsychotics, Seroquel, you have Maxiram, some of your prokinetics, Zofran, for instance. A lot of very common medications that we use in an ICU, it causes a QT prolongation. And that could become problematic because if the QT becomes too long for a longer period of time, about 500, and if the patient's magnesium is in the lower end, it puts them in states where they can develop an arrhythmia that we call torsade de points. So you want to make sure that you prevent that from happening by keeping an eye on your QTc. And this goes back to your monitor. In your monitor, there's an option for you to turn on the QTc monitoring. So make sure that you keep that in mind. Okay. Which brings us to our next letter, which is R. R for restraints. Unfortunately, a lot of your patients in the ICU, they will be restrained. Now, we use physical restraints and we also use chemical restraints. Chemical restraints in the sense of sedatives, narcotics, right? Sometimes paralytics. And physical restraints, it could be anywhere from just having the side rails of your bed up to soft restraints that you can see in the picture here, to sometimes the Pinel or the heart restraints. Now, we always try to make sure that we use the least restraint possible, but sometimes you're going to realize that when patients are in the ICU during the acute state of illness, right, and they're so uncomfortable, that they're going to try to reach for tubes and lines. And I can tell you from personal experience, I had that happen. Everyone had that happen to them, unfortunately. That and patients either they self-extubate or they remove their central line. So as a safety, not only for yourself as a nurse, but also for the patients, so they don't pull a lot of the lifelines that they have, you're going to see that some of the patients, they do have physical restraints to ensure their safety until they become a little more stable and more cooperative for the restraints to come off. Which brings us to the next R, which is repositioning. Crucial in the ICU. As you can see, the patients in the ICU, if they're sedated or they're decreased LOC, they won't be able to turn and reposition by themselves. They depend on us to do so. Now, we tend to do it every 2 to 3 hours, ideally 2 hours, depending on how your workload is. And every time you turn the patient, make sure you check the skin, check the coccyx, check for all those pressure points, right? Make sure those pressure points are properly offset. And make sure that when you reposition, as you can see over here, that you have sufficient help. Now, and the reason why is because some of the patients, they are quite heavy, and you might need additional assistance so that you don't injure yourself while you're providing care as well. Next letter is going to be S. Now, S, it stands for a few things that you're going to reassess and think about the back of your head. You're going to think about sedation. Does a patient still need sedation? Does a patient need frequent suction? Because that could be one of the things that keeps them in the ICU. For instance, if your patient needs suction every 10 minutes, they cannot go to a regular ward. The nurses, they do not have the resources to be suctioning the patients every 10 minutes, right? Because if you think about it, they go to a ward, they might have definitely more than one patient for sure. Sometimes they even have up to 5 or 6, and in some places even more. So it doesn't become safe for the nurse and neither safe for the patient. So that's something that you have to keep at the back of your head. Spines. We want to make sure that the patient's spines are clear, especially if you work in a neurotrauma unit. You want to make sure that the cervical spines are clear, the thoracic and lumbar spines are clear. If they're not clear, it does not mean that the patient cannot be repositioned. They still can, but you need to use lock roll. And if a patient needs to be lock rolled, then you need to bring in more staff. it usually takes at least 5 people to lock roll a patient safely to ensure that all your lines are still in place, make sure that you maintain neutral spine position, and make sure that all your staff are safe after the turn. Sleep, as we mentioned earlier with delirium, is one of the things that patients do not get enough. If the patients start to stabilize more, either try to turn down the lights during the night, try to minimize the noise in the unit if possible. I understand that sometimes that's not possible, but there's other options up there as well. If your unit, for example, has eye patches or earplugs that you can give the patients, provide them with that, to minimize some of the stimulus to try to encourage sleep. And then we have to reassess sedation, right? Does the patient still need these sedatives? Like, is it agitation related? Is it pain related, right? Because agitation, the patient can, it has many sources, pain being one of them, but then we have to make sure there's nothing physiological as well. So sedation is something that we reassess with the team every day for the need to have the sedation. Which brings us to our next letter T. Now, letter T, as you can see over here, it's for titration of drugs. What does titration of drug means is that patients in the ICU, they're going to be on a lot of continuous IV infusions. That means that the medication is put in a primary line in your IV, right? And is run in a continuous manner at a set rate. Now, usually the physician or the team is going to order for you to give you the freedom to titrate your medications based on certain parameters and based on some clinical manifestations. For example, your sedative, some physician might like it to be titrated to a sedation assessment score of maybe 2 or 3. Sometimes they might want a systolic blood pressure, less than 140, or they might want a heart rate, less than 90. And depending on the patient's condition. So based on that, you as a critical nurse, as a critical care nurse, you are going to have the knowledge, skill, and judgment to manipulate the dosages of all these medications until you hit the desired effect for the patient, either through numbers in your monitor or physiologically through clinical assessments from your patients, okay? So, but this comes with knowledge of pharmacology, especially pharmacokinetics and pharmacodynamics of your medications, and what medication works faster, which one takes longer, and this is the part where knowing some of the half-life of your drugs, it comes in handy as well. Which brings us to the next letter, which is U. Now, you make sure that the patient it's urinating. That tells us that the kidneys starting to work again, or the kidneys are working. But if they are not producing urine, we want to make sure that we bring up the ultra-filtration option. Now, ultra-filtration in the ICU is usually an add-on skill, like an advanced skill. And the reason why is because some critical care nurses, as they become more comfortable with caring for patients with, with respiratory and cardiovascular support, then they will learn ultrafiltration, as their training goes on. Now, this machine is the Prisma, and we call it continuous renal replacement therapy. Sorry. And it's one of the machines that we use to dialyze our patients in the ICU. This treatment runs continuously, right? And we're able to play around with how much fluid we want to remove, and we just have to do blood work quite frequently. But this is an add-on skill that you will learn. You don't need to know that right now, but just keep in mind that there is this option if the patients are extremely positive, diuretics are not working, and the patient is going into heart failure. So those are some of the options we can think about this and bring it up to the team. Which brings us to our next letter, V. V is going to be for your vent changes. Now, your patients, when they first get admitted to the ICU and they are sedated because we have to put the breathing tube in, they might need to be on a control mode, meaning that the machine is going to do all the work. The machine is going to initiate each breath based on what the respiratory therapist or what the doctors put in the machine. And the machine is going to support each breath. So it's going to do two functions. It's going to drive the breathing for them, and it's going to support every breath of the machine. As the patient starts to get better, we're going to let the patient breathe on their own. So the patient is going to be able to initiate their own breath in a support mode, but then the machine just provides a little extra boost in every breath to make the air go in a little easier. Because remember that the patient, when they still have the breathing tube in, it's like trying to suck in air from a straw. That's how it practically feels like, right? So, and it's not a normal type of breathing, and sometimes with that it does causes some problem with the patient. We want to make sure that we challenge the patient with the vent settings, because we cannot keep patients in the same ventilator settings for very long. And as a matter of fact, we don't want to keep patients in a ventilator for long, because then it opens a whole bunch of complications, barotrauma, ventilator acquired pneumonia, injury to the larynx, and so many other things that can potentially cause. So make sure that you consult with a respiratory therapist, with your team, to see how low can you go. And obviously, if the patient starts to show signs of respiratory distress, then that tells us that maybe it's not the time just yet. And this brings something up to what we call the SBT, the spontaneous breathing trials. Make sure that you bring that up to the team if the patient is a candidate to try spontaneous breathing trials. So in a nutshell, is we try to lower the machine settings as low as possible without extubating the patient, to see how long the patient can tolerate those zero settings or minimum settings. If the patient is not able to tolerate that, it tells us that maybe that's not a good time to remove the breathing tube. If the patient is able to do it, maybe the patient's getting better, and we should reassess that with the team. Okay? Brings us to the next one, W. This one is big in every hospital and every ICU, because patients sometimes, when they're so unstable, and when we turn them at times, the pressure changes, the heart rate changes. Sometimes they end up being in a bed for days if they're very, very, very sick. And when they're stable enough and we turn them, sometimes we find surprises in the skin. So make sure that doing every time you reposition, as we mentioned earlier, that you do a quick scan of the skin. Check all your pressure points, team. Coccyx, make sure your shoulder blades, the heels, any bony prominence, to make sure that there's nothing that is potentially getting red and could potentially open up and progress into different stages of pressure ulcer. Okay, if the patient has a pressure ulcer, a lot of hospitals, they do have the wound care team or the complex wound services. Make sure that they're involved in the care so that they can provide you with proper and the best treatment for the specific type of wound that you're seeing. Next is going to be X. X is going to be for X-rays, and you're going to ask yourself, does the patient need X-rays? Now, some hospitals and some ICUs still have, the daily X-ray policy. Some hospitals don't. I have worked in both type of hospitals where they have daily X-rays and only as needed. And it's going to be based on the patient's needs and also what treatments they have. Some places that they have chest tubes, they require daily X-rays. If the patient's condition changes, for example, you were hearing good air entry on one side at the beginning of your shift, and then all of a sudden there's no air entry on one side. We might want to see what has happened. Did the lung collapse? So keep that at the back of your head, and that's going to be based on your assessment if the patient requires any X-ray. And why? It's going to be for widen your IVs. Now, you have to ask yourself, is there a need to widen my IVs? Chances are your answer is going to be yes, because then we don't really have a lot of lines to kind of play with. And sometimes the central lines, the most common ones that they use are the triple lumen central lines. Some central lines have up to 5 ports that you can use. But the whole point of widening the IVs is for you to actually think about, are these drugs compatible? Because not every medication that you put together in the same IV tubing is going to be compatible. Sometimes there's no data right? And sometimes they're just not plain not compatible. And if you put two drugs that are not compatible, sometimes precipitates start to form inside the line, or they neutralize each other, which it doesn't provide any therapeutic effect for the patient. So make sure that whenever your patient stabilizes, that you're able to check for compatibility for all these lines. If your drugs are not compatible, advocate for the patient to maybe have different or more vascular access so that you can administer medications safely that way. And last but not least is going to be Z. And we want to make sure that you zero all your lines. And here I just put zero your art line. Okay. Now, some of the lines that you're going to zero, some places they have, for example, central venous pressure, CVP monitor. For those of you working in a CV intensive care unit, you're going to have your PA lines that you might have to zero. Art lines are the most common lines in the ICU, and art line stands for arterial lines. These are the lines that are going to be either inserted on the radial, most commonly, sometimes in the ulnar, or sometimes up in the brachial, depending on the patient's vasculature. And sometimes you also find them in the femoral side, what it does. So the main reason that you want to make sure you zero your outline is because every time that you draw blood and you open the system, right, it needs to be recalibrated. And the reason why is because the atmosphere has pressure. We want to make sure we tell the machine to ignore the atmospheric pressure, to only focus on the pressure inside the patient's vasculature so that your blood pressure becomes accurate. Why is that important? Because you want to titrate your inotropes accordingly, right? And that becomes very important for patients, to make sure that we are providing them with the correct treatment and that we're titrating the drugs accordingly. And that brings me to the end of the this presentation here. So I hope you learned something. Thank you for your attention. Please like and subscribe to my channel, Army of Nurses. If you have any questions, please send a comment. And happy learning for everyone. Bye for now.